My name is Dieuwke Broekstra, and I will present the results of our work about prevalence and incidence of Dupuytren's disease and lifetime risk of surgical treatments. Our research group received grants and fees from several industries, but none of these were related to this work. In the literature, a few reports exist of prevalence and incidence of Dupuytren's disease, but no previous reports are present of incidence of treatment or the risk of treatment after being diagnosed. And this is important to know since it can help you inform newly diagnosed patients about the expected course of their disease, and these numbers can also be used by policymakers or health commissioners. The research questions that we addressed were what is the prevalence of Dupuytren's? What's the incidence of Dupuytren's and the incidence of surgical treatments? And what's the lifetime risk of getting surgical treatment after being diagnosed? Two data sources were used for this study. The first is the Clinical Practice Research Data Link, the CPRD, which is a dynamic cohort of about 13 million patients from GP practices all over the UK. And we use this data set to get information about Dupuytren's diagnosis and dates. The second are the hospital episode statistics, which is a data set containing information about surgical procedures performed in hospitals in England. And we use this data set to get information about surgical treatments for dupes and dates. The outcomes, well, for prevalence and incidence, the outcomes were Dupuytren's diagnosis and Dupuytren's surgery. And for estimating lifetime risk, we looked at time from Dupuytren's diagnosis to surgical treatment or censoring. And in our analysis, we took the covariates age and gender into account. Prevalence was calculated as the number of Dupuytren's patients in the cohort divided by the total size of the cohort. And incidence was calculated as the number of newly diagnosed Dupuytren's patients in a certain amount of time, divided by the number of people being at risk in this cohort in this certain amount of time. Of course, it's not possible to observe all these patients throughout their whole life course to see who got treated and who didn't. So therefore you use a multi-state Markov model, which is depicted here in this graph. A Markov model is characterized by different states, mutually exclusive states, in which a patient can be in. So a patient can be in a Dupuytren's disease state, and once he gets treatment, he moves from the Dupuytren's state to the treatment state. Also, someone can die. So if that happens, the patient moves from the Dupuytren's state to the death state. This happens with a certain probability, the transition probability. And these transition probabilities from moving from the Dupuytren's state to the treatment state was estimated using the data, specifically spline regression. The transition probability of moving from the Dupuytren's state to the death state was derived from UK life tables of the Office of National Statistics. Then we run simulations. And what we did is that we created a cohort of 1,000 fake patients. And every year, part of these fake patients got treatment and another part died. And we let this happen years on and years on and years on until this cohort reached an age of 100 years. And the number of people being in the treatment state at that time defines the lifetime risk of getting surgical treatment. These are the descriptive results. We identified 39,000 Dupuytren's patients in our dataset, and among these there were about 4,500 people having surgical treatments. As expected, predominantly there were males in the datasets, and the age at diagnosis was 63, and the age at first treatment was 66. So there was about 3 years in between diagnosis and treatment. This graph shows the point prevalence of Dupuytren's, and as you can see, the prevalence is higher for males compared with females, and is peaking around the age of 70 to 80. The following graphs show the incidence of Dupuytren's disease. On the left side, specified for gender and across years. And you see a slight increase across time, but it stabilizes after a while. And which is also very obvious is that it's much higher for males compared with females. So males tend to have a higher risk for getting Dupuytren's. On the right side, we see also incidence of Dupuytren's, but then specified for age and year. And here you see that the incidence of Dupuytren's is peaking between the age of 60 and 70. This is the same graph, but then specified for incidence of Dupuytren's surgery. So whenever someone gets the first treatment. And on the left side, you see that it's much higher for males compared with females, and that for males it also tends to increase slightly, while it is relatively stable for females across time. On the right side of the graph, we see the incidence of surgery specified for age and years, and we see that it peaks between the age of 60 and 80. So most people get their treatment in these age groups. Now we get to the exciting stuff, because this is the graph showing the lifetime risk of surgical treatment for Dupuytren's disease. And you can see that it's much higher for males compared with females, almost double. Another very striking result is that it's also relatively stable across age. So someone being diagnosed at 40 has almost the same risk of getting surgical treatment compared with someone diagnosed at 80. That's interesting. If we look at the results, the prevalence and incidence rates of Dupuytren's is similar to other registries' rates, but much lower compared with studies in which a random sample was investigated prospectively. And the lifetime risk of surgical treatment is relatively low, but if we look at an Icelandic study, they found that about 12% of Dupuytren's patients were surgically treated after 18 years, so this is also relatively low. It needs to be noted that the risk is slightly overestimated for the general population, but underestimated for the hospital population, because our analysis made use of GP data, and we expect that these patients are less affected with Dupuytren's disease compared with the hospital population. This study benefits from a very large sample size and also relatively long follow-up. But unfortunately, we had no information on non-surgical treatments like collagenase, and we could only take primary surgical treatments into account and not recurrences. The take-home message is that men have almost double the risk of getting surgical treatment compared with women, but that the overall risk of treatment is relatively low. This study was funded by the following bodies, and I thank you very much for your attention.